Healthcare is confusing. Payer policies change, regulations are modified, reforms are proposed. We're breaking it down for you here on Inside Healthcare from Fulcrum Strategies. Hello, everyone, and welcome to Inside Healthcare from Fulcrum Strategies. I'm Matthew Handley, along with our president and CEO, Ron Howrigon. Ron, hello.
Hello, how are you?
I'm doing well. I hope you are as well. As we talked about in our last program on the government shutdown, which we are still in the midst of, our country might not be doing so well. The debate is still over the subsidies for the Affordable Care Act. The Democrats have remained firm on that. And Ron, I think your prediction in our last program was right that it was going to go on a long time. And if we haven't yet, we're very close to
Yeah,
breaking the record, I think.
yeah. I think if I remember right, my over under was 4 weeks, and I was taking the over, and we're there.
Yeah.
So I should have gone to Vegas with that one.
Well, as long as you're not involved with any mob families or anyone in the NBA, I think you'll be
There we
okay on
go.
that.
There we go.
Want to talk a couple of issues that are still surrounding this debate and also talk about the Affordable
Yeah.
Care Act in general. There's been several news items that have come up in the last couple weeks, and we'll have links to these in the description of the program as well. One of which is from Fitch Ratings, which takes a look at some of these companies and determines kind of how they're doing in response to certain news items. And one of them is on the U.S. health insurers amidst the
Mhm.
government shutdown. They're saying that the health insurers are facing a modest impact from the ongoing government shutdown. However, there's still some unknown risk just determining on where these tax credits are going to lie when it's all said and done. They write a prolonged shutdown and staffing furloughs could increase uncertainty and operational pressure for health insurers if enrollees are unable to receive guidance during the enrollment process. Medicare open enrollment has been underway for a while. ACA
Yep.
enrollment began this weekend. Ron, is what else can we expect from a report like this from an agency like Fitch?
No, I think Fitch has it right. As long as this doesn't extend for many more weeks and months, if you will, the shutdown itself for the insurance company is going to have a minimal effect, if anything. The bigger issue, and I know we're going to get to that next, is really what happens with these subsidies, what happens with the exchange plans and the Affordable Care Acts, in 26 more than the next few weeks.
Yeah, and it's been noted on a number of the cable outlets and in your regular broadcast news as well that the stock market hasn't reacted a ton to the government
Right.
shutdown. I would imagine that'll change a little bit again, depending on what happens. Um, as part of a compromise, which has become a dirty word in Washington sometimes,
Yeah.
the Republicans have put together some ideas in order to make the Obamacare subsidies a little more palatable. One of which is an income limit on who can get an ACA plan. The cap that they're proposing right now from the House Problem Solvers Caucus has been around $200,000. Is that an appropriate income cap, or does that already just include most of the people that are already on Obamacare?
Well, the people who are on the exchanges who are making more than $200,000 a year, first of all, are few and far between. Second of all, they could afford to buy primary insurance without the exchanges. So, in some respects, this is a little bit of a diversion, if you will, or smoke and mirrors, or and the first thing that popped in my mind when I saw some of these were band-aids on bullet wounds. It's just really not going to move the needle much. But politically, it says we're doing something.
Right. Another one is a minimum out-of-pocket premium. And part of that is to make sure that people know that they are on an Obamacare plan, an ACA plan. The Paragon Health Institute called some of these people phantom enrollees by calling them individuals who don't know that they're enrolled because their plan premiums are fully subsidized by taxpayers. I would suspect that that's probably not a lot. I don't know that it's as phantom as they want to make it sound, because you do have to enroll in it, even if you don't necessarily have a monthly premium because of the subsidies. Um, is a minimum out-of-pocket premium a viable solution to this problem?
I, I don't think it really changes anything because I think you're right. It's not that people don't know they have it; they enrolled in it, and for the most part, everybody uses the doctor at some point or another. So even if they forgot they enrolled, which I find unlikely, when you go to the doctor and they ask for your card, you can go, oh, yeah, that's right. I have this thing. So again, I just don't think that's at all a big issue.
Another one is grandfathering the tax credits that are on that exist right now. Anyone who has them gets to keep them. Any new enrollees don't get them. Uh, how about that? Is that a viable option?
Well, it's an option. I will tell you, it's an option that the payers don't like because when you think about it, a big part of what fuels the Affordable Care Act or the exchanges working are young, healthy people coming into the pool to help offset the risk. And a lot of these people that would be first time enrollees, if you will, just fall into just that category. I graduated from college, I got a job, it doesn't offer me health insurance, and I use the exchange. Or I age out of my parents', coverage because I turned 26. Keeping those people out of it creates a real problem for the payers.
Yeah. Well, and we've seen it just totally cannibalize some of these PE-backed groups that existed several years
Yep.
ago. Bright Health is the one I'm thinking of in
Yeah,
particular. Couldn't get the right population, just
exactly.
totally imploded on itself because of that. There's another one in this political article on abortion access. I don't know that that's actually really even necessarily connected to the issue here. Both sides have their ideas about whether or not
Yeah.
the Affordable Care Act actually funds abortion. So I'm going to skip over that one. But if you want to read it, it's in the Politico article. Another item that has popped up is from the Peterson KFF Health System Tracker. And it's talking about how much premiums are going up for small businesses, like ours in particular, in 2026. This is a little different from the ACA subsidies that we were just talking about, but it's important for all those that do have to purchase plans. States every year have to suggest and propose their premium changes for the Affordable Care Act plans as well as their small business
Mhm.
plans. The median plan is going up 11% in 2026, with on the high end being 25 or 30% or greater. Um, One of the things they say is driving up premium increases. Of course, they always talk about rising healthcare costs. When we talk to some of these payers, they put it squarely on the doctors. Is that a
Mhm.
fair thing to do to put it squarely on the doctors?
I think there's no data that supports that. If you look at for decades now, if you look at average physician compensation, okay, so if it were the doctors, they would be making more money. If you look at average physician compensation, it has not kept up with inflation for quite some time now. It's really not a great financial move to become a doctor, especially when you compare them to other high tech or white collar individuals. I mean, these are folks who spent 12, 14 years in college, so they could have done something else. So, no, it's not the doctors that are making it to a large degree. What we're experiencing with that trend is what a lot of people are calling the post COVID hangover. We're dealing with long COVID and we're dealing with pent up demand that didn't happen during COVID. But worse than that, and this bodes, big concerns in the future. We had 2 years where a lot of people didn't get a lot of preventative care. They were afraid of going to the doctor. They didn't get their colonoscopy, their mammography, all of these other screening things. And now we're paying for that. We're seeing cancers that are further along than we otherwise would have seen, et cetera. So I think that is really what's driving that trend a whole lot more than doctor income. In addition to that, we've seen inflation, general inflation, tariffs, et cetera. Well, hospitals, doctors, et cetera, are not immune to that. And so that's driving up cost as well.
Another list on here that some of these insurers cited was GLP-1 and high cost
Mhm.
drugs. Um, I know GLP-1s are being excluded for weight loss purposes from some of these plans. Is that a reasonable excuse to hike up premiums?
The GLP-1s definitely have had a huge impact in the spend, and it's new to the market, so it's obviously a blip. The big question for the GLP-1s, well, I think there's two questions. One is, will they come down in cost? And two, what is going to be the offsetting gain from reduction of cost from the GLP-1s? They're now showing incredible cardiac benefits. They're showing benefits for joint health. They're showing benefits for diabetes and et cetera. The problem is those benefits won't be felt for quite some time, where we're going to avoid a cardiac disease or a heart attack 3, 5 years from now by somebody who's taking the GLP-1s today.
Oddly enough, one of these, and I just had to bring it up because I thought it was interesting. Tariffs were cited by 23 of the insurers that participated in this tracker, mostly on pharmaceuticals and medical supplies. I know as the Trump administration works out some of these trade deals, that might go away depending on what happens. But I guess in my mind, I don't know that I expected that to be ranked as high as it was here on this list.
Well, first of all, tariffs is a great whipping boy for anybody that has to raise their price, whether it's direct or not. It's something you can use as an excuse, and I don't know that they're doing that, but it's easy because everybody understands it. The other thing, though, is it's a second order impact. To the effect that, let's say, a tariff increases the cost of a new MRI machine that a hospital has to buy. They've got to collect that from somebody else. Tariffs are nothing more than an indirect tax. So I think there's probably some credibility to that, and probably some, let's blame the tariffs for our premium increases.
Ron, if you don't mind sharing, I'd be curious to know what is our premium increase going up for Fulcrum Strategies this year?
Yeah, this was the first year we've had sort of what I would consider to be bad trend. Other years it's been small single digits. This year it's 15%. So we're
Yeah,
slightly above what the
we're above that
national average
median.
is. But everybody's getting into that range. I mean that number, that median number, is not at all overstating the real impact.
I was checking real quick to see if Blue Cross Blue Shield of North Carolina participated in this. They participate. They are saying their requested rate change to the state was 16.9%.
Right.
Also, North Carolina United Healthcare asked for 11.3 and 13.5, depending on the plan.
Right.
I the utility companies often have to do a certain amount of regulatory work when they ask for rate hikes too.
Right.
Here in Michigan, two of them recently asked for rate hikes, and the state government stepped in and said no. Um, can a state, or is it likely that a state would step into one of these payers and tell them, no, you can't hike the premium that much?
They can. Usually, what they do is make sure that that premium increase is based in actuarial science, and they typically are. Carriers aren't, don't ask for a whole lot more than what they think the trend looks like, and that's what we're seeing with why Blue Cross is very similar to United. I'm sure Cigna and Aetna have very similar numbers. So the state can decline it, but usually it has to be because they're not presenting, accurate numbers, or they're asking for too much profit margin on it.
Um, Is it possible? You take United Healthcare, for example, as a for-profit
Mhm.
company. We've picked on them before because of their earnings. Again, understanding that that's the point of a for-profit company is to make money.
Right.
Um, but I do think that some people are going to take a look at that and say, well, they made X billion dollars last year. Do they actually need that 16% increase in
Well,
Michigan or North Carolina or wherever it might be?
there's two things to keep in mind on why the payers don't try to overprice their product. First of all, the Affordable Care Act for fully insured business says you have to spend at least a certain percentage of that money on direct care. So if they overcharge, they have to just give it back in rebates to their customers anyway. So it doesn't make sense to do that. The other thing is, and this concept is why the exchanges are under significant risk right now, is you also don't want to get into the death spiral. You want your product to be priced competitively so you can attract those 25-year-old male healthy people. If you rate yourself too high, the only people who are going to stay on your plan are the really sick people, or the employers with large, with a sick population that they don't want to change. So, I don't think these rate increases from the payers are sort of trying to get abnormal profits, because they really can't in this population, and it could hurt them as they go into the death spiral. This is truly what's happening with medical expense.
Well, we'll keep tabs on this. Also, this week, the new 2026 Medicare physician fee schedule came out. We'll keep tabs on that as well. And once it's finalized, we'll provide you a summary right here on Inside Healthcare. Ron, thanks for your time today.
Thank you.